Welcome to our online information session. We're sorry that we can't be with you in person, but we've put together a series of videos to better help prepare you for surgery.
This month's sessions will include a presentation from Dr. Derek Stephenson, one of our bariatric surgeons, presenting an introduction to bariatric surgery, along with a question and answer at the end from both Dr. Derek Stephenson and Susan Shropshire, answering commonly asked questions. It will also include a presentation from Susan Shropshire, our bariatric clinical coordinator, presenting bariatric nutrition.
We hope that you enjoy the videos, and remember, at the end of the videos, please complete the quiz in order to gain your certificate of completion. We hope to see you in person soon. Okay, welcome to our online information session for Inspira's bariatric surgery program. Tonight's speaker will be Dr. Derek Stephenson with an introduction to bariatric surgery. Dr. Stephenson?
Hello. So as I said, I'm Dr. Stephenson. I'm one of the surgeons in our bariatric program here. I work along with Dr. Tia and the other surgeon in our system being Dr. Iqbal. I'm going to be giving a brief introduction to bariatric surgery, a short presentation to kind of explain a little bit of what we do, how we do it, and why we do it. So first, as kind of an introduction, just to explain a little bit about the importance of this issue, obesity is becoming a larger issue in the country and the world at large. It has a high economic cost and related to healthcare, but more important, it has a lot of high related health consequences, as obesity is one of the highest causes of preventable death, meaning people are dying from something that we could otherwise treat and manage. As a result, obesity is being termed one of the new health epidemics. And as you can see, almost a third of US adults are now considered to be obese. If you compare this to numbers saying back in the past, that number was as low as about 11%. When you consider the overall population of the country, a jump in that is a huge amount. So this is a problem that we're all facing together. So to kind of show that graphically, this shows the incidence or the amount of obesity in the population per state. And it works kind of like a stoplight. So green is a low percentage, not too bad. Yellow kind of being a little cautious, and the orangish red is starting to get a little high. So as it starts in 2011, we'll start going through the years. And then 2012, 13, 14, 15, 16, then up to 2017, what you're seeing are levels of obesity, as in the kind of dark burgundy, that didn't even exist back when we started. And so as you can see, this is a growing problem. And so as we deal with it, you'll hear a lot of different terms. And one of the most common when we're dealing with things related to obesity and especially bariatric surgery is BMI, which stands for body mass index. What this is, it's a screening test, meaning it's a quick method to kind of put people into categories, and it tells us information about them. And so we use your height and your weight, and we get a number. And that number is quick and easy to use, but it correlates with something that would be more difficult to do, such as body fat measurements. So this gives an example of the BMI. So the chart below, for someone at that given height, it'll show the numbers that the range would be for a given weight. And it breaks the categories into what's essentially considered normal or healthy weight to overweight. And then once the BMI gets above 30, you get into that category of obesity. And another term you might hear is morbid obesity. And so what this technically is being 100 pounds over your ideal body weight. An ideal body weight is just a more complicated formula that they created, and they take more factors such as age, gender, height, weight, and you have to put into this big calculator and it'll give you a number, and they'll say what someone's ideal weight should be. But that's too complicated to use regularly. And so we simplified it and we use the BMI, which is much more commonly used to represent it. And so a BMI greater than 35 is considered morbid obesity. And this is important to us because it fits into the qualifications of who can get weight loss surgery. So the general initial qualifications are based on the BMI, or the body mass index. So if you have a BMI greater than 40, that in and of itself qualifies most people for weight loss surgery. If your BMI is between 35 and 40, you need a medical condition related to weight issues. If your BMI is less than 35, you generally don't qualify for a surgical procedure and have to look into other options such as diet, exercise, and medication. So what are those weight-related medical conditions? These are all things that either develop or worsen as weight increases. They include things such as high blood pressure, diabetes, high cholesterol, sleep apnea. And so the list is growing, as you can see. But the good news is these are all things that improve or in some cases go away as weight goes down. And so people with high blood pressure after the surgery, their blood pressure gets better. Hopefully they can get off their blood pressure medicines. It's very good for diabetes. A lot of people who are on insulin can get off insulin and sometimes off medications entirely. For sleep apnea, if you have a CPAP machine, over time you can wean that off and no longer need that. And even things such as cancer risk and heart disease, they're finding the risk goes down as weight decreases as well. And there are even more studies that they're doing and finding more benefits for things such as fatty liver disease. They're seeing some reversal in that and effects on the immune system. So overall, we're finding a lot of benefits to weight loss surgery. And this gets into kind of why we do this. The main reason is for health. As physicians, our goal is to treat medical problems. And so through doing these procedures, our goal is to improve or resolve all these medical conditions, stop people from getting them if they don't have them, because they would over time, hopefully get people off medications that they no longer need, and in the end, improve their lifestyle so they can live a longer, healthier life. So that gets into the procedures we do and how we do them. And so surgeries, especially surgeries in the belly in general, can be done in one of two ways, what we call laparoscopic or open surgery. So open surgery is the way things used to be done years ago for any surgery, where they make a big incision kind of down the middle of the belly, and then they go inside and do whatever they need to do. But now with laparoscopic, instead what we do is we make very small incisions, and then we inflate the inside of the belly with a gas and go inside with a camera. And we can do a lot of the same surgeries that way. And this has a lot of benefits. It allows faster healing, decreased time in the hospital, usually less pain, because most of the pain from surgery actually comes from the incisions. When you make a big, large incision, there's a lot of pain. With these very small incisions, there's not much at all. And this allows you to get back to work faster, and there's less scarring, both on the outside, because smaller cuts heal better, but also on the inside. Because when you do surgery inside the belly, the body responds naturally by creating scar tissue. When we make an open surgery, it does a lot of scar tissue, but when we do it laparoscopic, it barely makes any or sometimes none at all. The procedures themselves can be split into two kind of general categories, which is based on how they're performed, or more how they work. So the first would be restrictive, meaning it restricts or limits what you take in. That would be mostly the sleeve. And then there's malabsorptive, which has a restrictive component, but mostly works by changing the way your body processes or absorbs the food you eat. And that would be the gastric bypass. Now, the lap band, we kind of talk about almost more historically, but it was pretty common some years ago. As you can see in the picture there, it's essentially a small balloon, if you can imagine, wrapped around a plastic collar. That collar we wrap around the top part of the stomach, and it's attached with a cord to a port, which we implant under the skin in the belly. And then when we're ready to adjust it, we would use a special needle to inject fluid into the balloon so it inflates and squeezes on the top part of the stomach, which, as we said, restricts how much you can take in. The problems we found with it, however, were it didn't work as well as the other procedures we do, mainly the sleeve and the bypass. Although some people had good results with it, on the whole, the weight loss was lower overall, and it was also slower. And then that adjustable part can be kind of a negative because it means you have to come to the office, get poked with a needle so we can inflate the balloon. But if we inflate it too much, then when you go home, you try to eat and nothing goes down and you're throwing up. So we have to deflate the balloon, but then it's not squeezing or doing anything. You kind of bounce up and down. so you can get a perfect level. And then over time, we found issues with it, such as it's a foreign body, the body reacts by trying to fight against it. We can develop things like hiatal hernias, the band can slip, and over time, we end up having to take a lot of them out. So the band we don't actually do anymore. But the main procedures we do are the sleeve and the bypass, with the sleeve probably being the most common at this point. So this video will kind of show a little illustration-wise, both the procedure for the sleeve and also how we do the surgery laparoscopically. So as you can see outside, with the laparoscopic surgery, we make very small incisions, usually 5 of them. And then these are trocars that give us access to the inside of the belly. And as I said, we inflate the inside with a gas so we can see, and we go inside with a camera and do all our work with instruments, kind of like this. So as we get to the inside, this shows kind of the normal anatomy of things the way they are now. And when you eat, food comes down the food pipe into the stomach, and the stomach's main job is to work as sort of a reservoir. And so it's almost like a balloon, so it expands as you eat more until it gets full to the point where it can't take any more. And so with the sleeve, what we do is we come in and we cut the stomach, similar to this, and that whole portion we take out and remove, leaving a small tube that looks kind of like a sleeve of an arm, which is why they call it that. And then by doing that, what we've done is remove a lot of the portion of the stomach that stretches when you eat. So now when you eat, the food comes down the normal way it does, but it takes less of it for the stomach to stretch all the way, which sends a signal to the brain to say, I'm full, and causes you to no longer feel hungry. But the food still gets absorbed and processed the way it normally was, and this overall leads to the weight loss. So the benefits of the sleeve, probably most importantly, is that it works. We see excellent results with it because we're really just changing the size of the stomach. There's no real dietary restrictions, which we'll get into a little with the bypass. And there's almost no nutritional deficits as well. It's a little less complicated of a procedure to perform. The only kind of real downside is it's permanent because the part of the stomach we're taking out is being fully removed. The other procedure we perform is the gastric bypass. This is a little bit larger of a procedure. It's also done laparoscopically. So similar to the sleeve, you'll see the small incisions, usually about 6 for the bypass. Then in the same way, we use the kind of instruments in the camera on the inside to do the whole surgery. And so again, normal anatomy on the inside. But this time with the bypass, we're not actually taking anything out. We start by separating the top part of the stomach from the rest of it to make a small pouch. But then we actually come down to the intestines or the bowels and we cut them and then reroute them or move them up to that new part of the stomach, kind of like moving plumbing around. But now that other part of the stomach still stays there and makes acid and things you need. And so we reattach the bowel to itself down below so it has somewhere to go. And so now when you eat, the food comes down that new pathway, and the things you need to digest your food come down the old system on the left, but they don't meet up until they get all the way down where we attach the bowel to itself, which causes the body to not absorb as much from the food you eat, which leads to the weight loss. So benefits of the bypass, it also works. It's been around the longest of the procedures. They've been doing it since about the 60s, I believe. But it does have some downsides. The weight loss can actually be too much because we're changing the way your body's processing or absorbing the food. It doesn't absorb enough of the vitamins, especially certain vitamins that are absorbed in the part of the stomach we're skipping, people can get deficient in. And so when you have the bypass, you have to take extra of these vitamins essentially for the rest of your life. As long as you take them, you'll be fine. But if you don't, you can get very sick with it. And then there's something called dumping syndrome you have to be more aware of. This means if you take something that's kind of heavy in carbs or sugars, the body isn't used to processing it now since it's going straight to your intestine. And so it responds by giving a huge dose of insulin. You can get cramping, start feeling nauseous or vomiting, and diarrhea. And so this is something that you hopefully try to avoid by limiting those foods, but still something to keep in mind. So a little more details about the procedures themselves. The sleeve, as we said, a little less complicated of a surgery. So it says here about 40 minutes, and you can actually usually get that between 30, 35, 40 minutes. Most patients stay one night in the hospital afterwards. Bypass, definitely a little more complicated. Usually takes about 2 hours or so to do, and you usually stay 2 nights in the hospital. We don't give specific numbers of weight loss anyone should expect because everyone is different and each person has different goals and needs. But in general, we see about 10 to 12 or so pounds of weight loss per month for the first 8 to 12 months. Again, that'll vary more. People who have more weight to lose tend to lose more faster. Men tend to lose more faster in the beginning, but tends to equal out in the long run. So the process of things from here, most people have started by meeting with a surgeon. If not, you can call our office and we'll discuss with you kind of the options and review your specific insurance requirements. Those will usually include meetings with nutritionists, these informational meetings, a psychiatric evaluation. Once that's all completed, you get approved, there's still a few more steps to do. At that point, we'll do a medical evaluation to look through any medical conditions you may have. If you need any special workup, meaning if you have a history of lung disease or lung problems, we may send you to a lung doctor. If you have a history of heart problems, we may send you to a heart doctor. If you don't have any of that, we'll probably just send you to your primary doctor for a general clearance. There'll be some lab work we do, which is kind of the general lab work we do for any abdominal surgery. We'll look through your medications, see if there's anything that you either need to stop taking or keep taking. There may be imaging, which your surgeon will tell you specifically for you. Some people might get an upper GI to look at their stomach. Some people might get an ultrasound. If you have a history of stomach problems, we might do a scope study instead. So those will be set specific to each person. A special note there at the bottom to keep in mind is that everyone must stop smoking before the surgery. We actually do a blood test to check for it. So if you're smoking, now is a great time to stop, and that'll have a lot of benefits beyond this on your health. And then as we get closer to the surgery, there is a special diet we'll put you on before the surgery. As it says in the note there, don't worry about these yet because these details will come once it gets closer to that time. But it's not just liquids, but usually a small shake in the morning, a small shake at lunch, and then a small sensible dinner. There'll be a pre-op class, and we'll give you the times for those once you're able to schedule it. And then a final visit with your surgeon where we'll review your lab results and answer any questions you have. And the goal of all of this is to make sure you're kind of fully informed and prepared for the changes that will happen after the surgery. And then once you finish the surgery, there is a staged diet we put you on that progresses back from liquids to regular foods. So long term, you should be eating normal food. There's planned follow-up with your surgeon, which is important. We consider our patients for life, so you can always see us. But we like to follow up just to monitor your progress, see if there's any issues. If so, try to address them sooner rather than later. We'll occasionally check some lab work. This has become less frequent. If it's just a simple stop-in to say everything's doing well, no problems, then great. Then keep in mind there are support groups available after the surgery. These are people who've had the surgery and have been living with it day to day, and they know things about how to deal with problems that come up better than even we might. So these groups are free and available to everyone. You don't have to call ahead of time or reserve a spot. You can just show up, and we encourage everyone to attend these as much as they can.
Okay, we'll get started with some questions. Sue?
Hi, Dr. Stephenson. So I've got some questions that we often both hear from our patients. First, if I'm going to lose all this weight, what happens if I have a lot of extra skin afterwards?
So loose skin can happen after surgery. It's not necessarily going to happen, but it isn't an uncommon problem. People who have more weight to lose generally develop more loose skin. As far as how to manage it kind of depends. Some people say it doesn't bother them and they just kind of live with it. If it does bother you, you can try things such as like tight clothing, spandex, and those natures to kind of cover it. But if it really does bother you, then the last resort would be surgical options. But those we recommend you wait at least a year to a year and a half till after your surgery before looking into. And you usually need to see a plastic surgeon for those.
Well, what if I'm not done having children? What about pregnancy?
Well, you can get pregnant again after the surgery, but we recommend you wait again a year to a year and a half afterwards before doing so. And the reason for that is the large part of the weight loss after the surgery is in that initial year. And if you get pregnant during that, you and the baby will be fine. But when you get pregnant, you need to put on weight because you're essentially eating for two, and that's natural and normal. But if you do that, you're not going to get the results from the surgery, and you've essentially kind of wasted the opportunity in that largest weight loss period. So try to avoid getting pregnant during that period. Now, in relation to that, if you take birth control, we do want you to not take that a month before and through a month after your surgery. And so you have to be a little extra cautious during that time as well.
Well, who decides which surgery I would have, me or my doctor?
So the final decision is always the patient's, because obviously we're not going to do a surgery on you that you don't want. But we will make a recommendation on what we think is best based on your specific needs and health history. So these are discussions you should have with your surgeon. If there's a particular procedure you want, tell them and explain why. We'll give you our recommendation and the benefits and negatives to it. But in the end, the decision will always be yours.
What if I don't lose the amount of weight I'd like to lose, or if I start to regain it, what happens then?
So as we said, that's why the follow-up with us is important, because we'll be following along with those and we'll look into reasons why. We'll check and make sure there's nothing physical that's going on. We'll review your diet. We may have you repeat a visit with the nutritionist and make sure there's nothing along those lines. But in the end, if you're having issues with weight gain, there are some other options we can review. There are things such as medications, or in some cases, even revision surgery, although hopefully it doesn't come to that.
Thank you very much. I appreciate your help.
Thank you both so much. That concludes our information session this month. Please remember to complete the quiz after the information session videos are viewed, and then you'll be emailed a certificate of completion, which you'll bring to your surgeon's office.
Welcome to the second part of our online information session. Susan Shropshire will now present a nutritional PowerPoint on portion control and bariatric nutrition.
Hey, everybody. Again, I'm Susan Shropshire. I'm the Metabolic and Bariatric Surgery Program Coordinator for Inspira, and I'm going to present a PowerPoint on portion control that was originally developed by Diana Alvarado, one of our outpatient dietitians. And since we can't be here in person today, we're going to use this format. What do you call a fake noodle? An impasta. Hey, everybody laugh. We're going to have fun today. All right. So the objectives of this PowerPoint is to help you to understand the importance of portion control, what it is, where we find our distortions, and to learn some strategies for portion control in knowing the appropriate sizes, using food labels, and slowing down our eating process. The importance of portion control is it's essential for weight management. I mean, you have to measure what you're eating. You need to lose some weight before surgery. It's especially important in prevention of weight gain after surgery. Portion control prevents complications after weight loss surgery due to over amounts of food. And portion control is part of meal planning. It helps us to figure out our nutritional content, and it assists with making meal combinations. So the definition of a portion or a serving size is it's a measured amount of food or drink, such as a half cup, a quarter cup, a fistful. Portion control is to know how much of a specific food or beverage and to eat that controlled amount. So where does distortion take place? Distortion takes place inside and outside of Americans' homes. America's portions are distorted. So if you look at the three plates below, you'll see the amount of room the first portion takes up on a plate, the amount of room the second portion takes up, and the amount of room that is swallowed up by the third portion. And nobody should be eating that amount of food in one sitting. This is a balancing act. Calories are in food. It's in the form of energy, and if you take in more calories than you expend in energy, as in activity, walking, gardening, riding, golfing, swimming, anything like that, you will gain weight. If you take fewer calories in than you put out in your energy and activity, you will lose weight. So larger portions really add up. Think of it this way, 100 extra calories a day will add up to a 10-pound weight gain per year. So figuring out how many calories you need a day is important too, so you know how many are the extra. Maintaining a healthy weight is a balancing act. So in this picture, you'll see creeping portion distortion, how food portion sizes have changed in 20 years. And if you look at the plates that are in the square, you'll notice there's a ring inside of it. These were developed, these plates were made so you know where the food stops. You're not supposed to bring food all the way out to the rim, only to the circle. A cheeseburger. Everybody loves a cheeseburger. 20 years ago, it was a few bites. It was wonderful. Today, it's really big, and the only good thing about it, it's got lettuce on now. Can you guess the calorie difference? So 20 years ago, a little burger was 333 calories. Well, that's not bad. But today, it's 590 calories, almost double in size. The difference is 257 calories. So how long would you have to lift weights to burn about 257 calories? An hour and 30 minutes. I have an exercise room and I lift weights, and there is no way I could lift weights for an hour and 30 minutes. After 5 minutes, my muscles are burning. French fries. French fries. 20 years ago, you got it in a little sleeve. Today, it's like a bucket. Big difference. 210 calories was a 2.4 ounce serving 20 years ago, and today 610 calories. Big difference. So the increased size difference is 400 more calories. How long would you have to walk leisurely to burn approximately 400 calories? An hour and 10 minutes. Soda, one of the worst things ever invented, really bad for your body. I know it tastes good, but it's really bad for you. 20 years ago, it was a 6.5 ounce bottle, 6.5 ounce bottle, and today it's 20 ounces. Guess the calorie difference. 85 calories compared to 250 calories. It's almost 3 times as much. The difference is 165 extra calories. So how long would you have to garden to burn about 165 calories? Well, about 35 minutes. Problem is, when you're done gardening, you're thirsty again, you come in, you grab another soda. So let's take a closer look at these food items. Today's burger, 590 calories. Today's fries, 610 calories. And today's soda is 200 calories. The total calorie intake is 1,450 calories. And for most of us, this is much more than is needed in a day. And we're talking about only one meal here. This is only one meal. Coffee. Look at coffee 20 years ago. 8-ounce cup with whole milk and real sugar was only 45 calories. Today, Mocha coffee, 16 ounces with steamed whole milk and mocha syrup, 350 calories. What's the difference? 305 calories. And that's just for coffee. So how long would you have to walk to burn about 305 calories? An hour and 20 minutes. And again, when you're done, you're thirsty again. What do you come in and drink? So how about some strategies for portion control? One, let's avoid the portion traps, just like we've discussed. Know the recommended portions. What is a portion? You find that on your label. You find that in what we've taught you. Learn how to measure the appropriate portion sizes by measuring tools, plates method with smaller plates, supportive dishware and containers. Learn to read your nutrition facts label. It's very important. And slow down your eating. Don't gulp your food down. Inhale it on the run. Portion control, portion distortion traps outside of the home are buffets. Ugh. Who hasn't gone in and said, yeah, well, I want to get my money's worth? And then you eat many more calories than you probably should be. Size of your restaurant meals. Size of your restaurant meals is important because they often bring you much more food than you should be eating. You can ask for a box and take part of it home. Baskets of breads or chips at the table are devastating to your calories. Just ask the waitress to take it back or not to bring it in the first place. Portion distortion traps inside the home are larger than recommended plates and eating utensils. Start learning to eat on a smaller plate. Your brain still sees a full plate. It doesn't say, yes, but it's a smaller plate. And you will find that you can eat the same amount that takes up the same amount on a plate and you will feel full. Grocery stores, don't ever go hungry. You'll buy everything in sight. Shop from a list and stick to it. And if you can't, call it in. Grocery stores nowadays, you can call your order in and pick it up, and they do the shopping for you, and there's no temptation. Protect your home from temptation. And please do not eat directly from a bag or a container, because you never know how much you're eating. How much will your new stomach be able to hold after surgery? 2 to 3 ounces, and sometimes up to 4 ounces, depending on your surgery. It's important that you don't stretch the stomach out by overeating so that you keep that size. So get the right tools to measure accurately. A food scale, very inexpensive. Buy it at Walmart. Measuring cups and spoons, even the dollar stores have them. No excuse to not measure. You can measure with your body too. Eyeball recommended portions with a helping hand. This is a woman's hand, by the way, not a 7-foot-tall man's hand. The palm size is meat portion, which is about 3 ounces. Cupped hand is about a half a cup. A joint, the tip of your thumb, is 1 teaspoon. Your entire thumb is 1 tablespoon. And the size of your fist closed tightly is about a cup. It's a handy guide right on your own body. Another way to look at it is 1 cup equals the size of a baseball. Everyone knows what a baseball looks like. 3/4 cup is a tennis ball size. So grab your dog's tennis ball. 1/2 cup is the size of your computer mouse. 1/4 cup is equal to an egg, and 3 ounces is equal to a deck of cards. A ping pong ball is about 2 tablespoons. Pretty easy to measure that way. Please use the nutrition facts provided on the food label as useful and much needed information. What should be the first thing your eyes look at on a food label? The serving size. It's very important that you don't buy something and just eat the entire amount when it was 4 servings. You need to know that 100 calories is for 1 serving, not for the entire bag. It'll always be the first thing under the word nutrition facts. It's usually in green on the new labels. It's very easy to read. Then you want to look at your proteins, your fats, your vitamins. There's all sorts of good information on there, and it's important to know what you're eating. Your calories are always listed there. They're all also, by the way, listed in these restaurants. And if you don't see it on the menu, you can ask. Use portion-controlled dishware and utensils. You can use the idea of vegetables should take up half your plate, carbs should take up a quarter, and proteins and fats on another quarter. Use the appropriate size dishes. Again, go to a smaller dish and use smaller utensils if that will help. Try to aim for at least 30 minutes for each meal. Schedule your time to eat. Don't eat on the fly. Don't eat at your desk. Don't eat in front of the TV. Slow down and actually taste your food and enjoy it. Try to chew about 20 to 25 times before swallowing. This is where digestion begins in the mouth. You need to chew your food down to a gruel or a consistency like oatmeal. Putting your eating utensil down between each bite helps you to avoid preloading. That's getting your next helping ready. Scooping less food onto your utensil, smaller utensils, and smaller plates and bowls are all very helpful in eyeballing a proper portion control. In summary, take control back when it comes to portions. Please make sure you have measuring cups, spoons, and a food scale for the kitchen. And please start to measure and weigh your foods to retrain your brain to portion control. Does anybody have any questions?
Okay, so some of the questions that we get asked a lot from patients is regarding how to be successful after surgery and to avoid that weight regain once they get back to eating regular foods.
Well, it's very important that you pay attention to what we said about portion control. It's so easy to just grab a bag, grab a can, grab a box, and not be cognizant of how much you're really eating. Measure it out, take a serving size, and make sure you practice this when you go out too.
Speaking of going out, that's another question we get asked a lot, especially patients with families. Will they ever be able to eat out again and enjoy themselves at a restaurant?
Sure, absolutely. Of course, you know, if you go to a buffet, you can't take a box home. So I don't recommend buffets because you just are so tempted to try to eat as much as possible to quote, get your money's worth. But when you go out to a restaurant, ask the waitress immediately for a box. So by the time your meal comes, you're all ready to separate it out so you only have a portion size. And then you have enough for a couple more meals, and that's pretty neat too.
Great. Thank you so much, Sue. It was very informative. And again, for patients, just make sure that you view both videos and complete the quiz at the end. Thank you so much.